the last topic over here is going to be talking about, well, what happens in the medical ICU setting. And the one question they always ask about is ARDS. So when we talk about ARDS, number one, I'm going to give the classic definition first, and then we're going to talk about how do we make the diagnosis for the boards. So the classic definition of ARDS is what you see up here. Number one, a PF ratio less than 200. Many people are going to ask me, well, what is a PF ratio? The P stands for the PaO2, and the F stands for the FiO2. So let's talk about me. If you were to do an ABG on me, what would my PaO2 be? Probably right now, I exercise, I don't have any bad habits yet. It'll probably be what? 100. And what percent of oxygen am I breathing right now? 21%. So if you take 100 divided by 0.2, what's the number? 500. So what happens in ARDS is that the PaO2 goes down, you give more oxygen, the FiO2 goes up. What happens to that value? It gets lower and lower and lower. And ARDS was traditionally thought of a PF ratio less than what? 200. You want to have acute bilateral imaging findings. And in the olden days, you want to have a pulmonary capillary wedge pressure that was normal to low. Why was that? Is because what other pathology really mimics ARDS on imaging? Heart failure. And of course, if you have heart failure, the wedge pressure is going to be what? Elevated. But in the year 2023, do we go around swanning everyone to make a diagnosis of ARDS? No. So we have new criteria now, the Berlin criteria. And we're going to be one of the main things is that, you don't have to do a Swan-Ganz. You need to rule out cardiac by other means, whether it's a brain natriuretic peptide, whether it's physical exam, whether it's going to be doing an echo, and your symptoms need to begin within 1 week of a known clinical insult. And we're using the PF ratio to really call ARDS mild, moderate, or severe. So if your PF ratio is greater than 200, we call that mild ARDS. If it's going to be greater than 100 but less than 200, moderate. And if it's less than 100, we're going to call that severe. And notice, what do they add here? That to get this PF ratio, it assumes that the patient's on a PEEP of at least what? 5, which really the take-home message is, when you use the terminology ARDS, we only manage ARDS when you're on the what? Ventilator. We don't manage it non-invasively. Very good. So what causes ARDS and how you're going to remember it, not memorize it for the boards? Look at this picture over here. Now look at my hand. This hand is going to be one alveoli. When we talk about hand as one alveoli, what happens when it's ARDS? The alveoli is going to what? Shrink up. It's going to shrink, and not only it's going to shrink, it's going to be filled up with what? Fluid. So when you look at this classic picture over here, here's the good side of the alveoli, here's the bad alveoli, it's shrunken up, and it's filled with all this fluid. So the question becomes, well, where did this fluid magically come from? So I put this slide here to say that, well, when we talk about ARDS, how does it mimic heart failure? So when you have heart failure, everyone, how does the fluid go in the alveoli? Well, hydrostatic pressure, meaning that the left ventricle is not working well, all the fluid backs up and sequesters out from the capillary into the interstitium. But when you have ARDS, it's not a heart problem. What happens is over here, if you look at the right, that all these proteins in the capillaries, because the pulmonary vasculature is very friable, these proteins go into the interstitium. And proteins are like oncotic pressure. Oncotic pressure is like sponges. They suck the fluid to it. So when it's sucking all the fluid out of the vasculature, it goes where? Into the alveoli. And this is how we get all this inflammatory exudate into the alveoli. So what causes ARDS? There's direct causes, indirect causes. Direct means any direct damage to the lung itself, pneumonia, aspiration. Indirect causes, I listed a lot, pancreatitis, trauma. But probably the most common cause of ARDS is always what? Sepsis. So red pen moment, circle sepsis really big. And how many times have you folks seen someone who comes in, gram-negative rods, turns out to be E. coli, the next thing you know what? ARDS. It happens all the time. And so, of course, we want to treat the underlying cause. So take a look at this. This is going to be a classic way ARDS is going to present. So right here, I see a consolidation of what? The right lower lobe. And take a guess. How did someone get a pneumonia in the right lower lobe? You got it. Amazing people. So then what happens 2-3 days later is this over here. So when I look at this chest x-ray, the first question I want to ask everyone here and who's listening is, what type of disease is ARDS? Is it a homogeneous lung disease or a heterogeneous lung disease? What do you think? Just looking at the x-ray. In my opinion, I want to say this is heterogeneous. Very few things are homogeneous in the body, in life, because that means both lungs are equally what? Affected. Now, when you look at this, do you see some kind of aerated lung here and some really bad lung here? There's kind of good lung and bad lung, good lung and bad lung. And that's very important when you manage ARDS because really, what lung, what alveoli are you really trying to save? The good alveoli or the bad? The good, the bad's done. Bye-bye. You know what I mean? You really want to save the good alveoli. So we do things to protect the good alveoli. Also, this patient's what? Intubated. So you only manage the ARDS on what? The ventilator. So remember, we want to save the good alveoli. And let's talk about how we do that. Now, here's a trick question for everyone. If I were just to grab you and say, hey, only based on this chest x-ray and only that, does this patient have ARDS? And what would you folks say? And the answer is, I don't know. And why is the answer I don't know? Who could tell me what's the PF ratio? Is this acute or chronic? So you know what's the game? The game is I can make this anything I want. So if this patient came from Guyana or India and is PPD positive, what's this? Miliary TB. If this someone has HIV, CD4 count less than 200, what's this? PCP. This has a brain natriuretic peptide of 4,000 and has an EF of 15%. What's this? Heart failure. So you need to meet the criteria if you want to call it what? ARDS. So how do we treat it, everyone? Treat the underlying cause. With sepsis, you're going to treat the sepsis, choose the right antimicrobials. We want to give hemodynamic support for these patients. And of course, medications. Let's say one or two things about steroids. ICU medicine is kind of like a pendulum, right? Some days, some months, some years, we love something. The next time we hate it. So you always have to know where you are in the pendulum. So steroids for ARDS, long time ago. Look at the bottom line point. It said, you start giving steroids to ARDS 2 weeks after the onset, you may increase what? Death. So no one gave steroids. Then further up studies show, well, if you gave steroids, but you gave it early in the course, well, it may reduce the stay in the ICU. It may reduce mechanical ventilation. Now we use it again. So what is the take-home message here is that it worked because we gave it what? Early. And that makes sense because that's where we lead to different stages of ARDS. You could have the exudative phase that leads to fibroproliferative, that leads, unfortunately, to the fibrotic. So if you want to give anti-inflammatory like steroids, the take-home message is you have to do it what? Early. But the problem about giving it early is that most of these patients are what? Septic. So it's really hard, you know what I mean? But I wanted to show how to pick answers on the board exams. So mechanical ventilation, for the IM boards, I really want to focus on two things. Number one is that if I were to ask you the question, what is the only thing in mechanical ventilation, only thing on the vent that's been shown to reduce mortality in ARDS? What is the only thing that's been shown to reduce mortality in ARDS? And the answer is low tidal volumes. So when I say low tidal volumes, everyone, I'm not talking about a smidge low. We are taking your tidal volumes and almost cutting them in what? Half. So let me just ask everyone this. Is it pleasant to cut your tidal volumes in half? It's horrible. Are there going to be other consequences of me cutting your tidal volumes in half? The answer is yes. So why do we do such a horrible thing for our patients? It's because studies have shown it improves what? Survival. And how do we think about that? Well, if you give big tidal volumes and these huge tidal volumes go to the good alveoli, those good alveoli are going to what? Rupture, barotrauma. And that's why we do that. So remember, we'll accept all the physiological consequences because we know giving low tidal volumes improves survival. Okay? And one of these consequences is right here, permissive hypercapnia. You give low tidal volumes, what's going to happen to the CO2? It goes up. So things to think about. So, with all this being said, you're going to ask me, well, how are they going to put that into a clinical vignette, Raj? So, 63-year-old woman is admitted to the ICU for septic shock secondary to community-acquired pneumonia. After antibiotics, fluids pressors, her condition stabilizes. However, she subsequently develops ARDS and is what? Intubated. Her O2 requirements increase until she's receiving 100% on the ventilator. Vent settings are a volume controlled. We call that VAC, volume assist controlled or volume controlled continuous mandatory ventilation. The set respiratory rate is 22. Tidal volumes are 330 mLs, which is already 6 mLs per kilogram of body weight. FiO2 is 100. The PEEP is 5. The peak pressure is 25. Plateau is 22. And on exam, low-grade fevers, normal tensive, tachy, and of course, the respiratory rate set on the ventilator at 22. Skin is cool. There's no JVD. Heart sounds are rapid and regular, but otherwise unremarkable. Diffuse crackles are heard on pulmonary exam, and there's no edema. The remainder of the exam is non-contributory. They do an ABG on the vent. The pH is what? Low. The CO2 is what? High, and the PO2 is 54. Chest x-ray, bilateral findings. So what is the question? Which of the following is the most appropriate management at this time? What do you folks want to do? A, decrease the tidal volume, implement prone positioning, start inhaled nitric oxide. D, decrease the respiratory rate. E, increase the PEEP. Here we go. All right. So the key thing is looking at that ABG right here, right? So what is the most worrisome part of that ABG? What scares me the most? What? Oh, you're awesome. The hypoxia. This is not even a smidge. This patient's on 100% FiO2, and the PO2 is what? 54. So why is the CO2 elevated? I did it. You did it. This is what? Permissive hypercapnia. Your folks are amazing. So which ones don't make a lot of sense to me? Should we lower the tidal volumes even more? No, it's already what? 6 mLs. Should we decrease the respiratory rate? That sounds like a bad idea. You know what I mean? The patient already has a respiratory what? Acidosis. So what about, is nitric oxide going to be the next thing to do to help out with oxygenation? Probably not. I think it comes down to B or E. And don't get me wrong, in COVID times, we were proning everyone. God bless our physical therapists and everyone. They're amazing people. But you know what? The first thing to do in someone who's hypoxic is to increase the what? The PEEP. And what do we increase the PEEP to? What do we titrate the PEEP to? The plateau pressure. And that's why we had to know what a plateau pressure is and is the value elevated. And at a plateau pressure of 22, is that elevated? The answer is no. We worry about it when the plateau pressure is above what? 30 to 35. So what's a nice simple thing to do here is increase the what? PEEP. If the PEEP was already maximized and this was COVID, sure, you could twist my arm and say what? Prone position. You know what I mean? But let me just do a couple more things here. Oh, this one is going to be the one where there's absolutely no memorizing here. This is to see if you understand what we spent all this time talking about ARDS. And I got to tell you, this is my favorite question. So a patient with ARDS is on the ventilator with the settings of 12 mLs per kilogram for the patient's tidal volume. But since he has ARDS, they switched it to what we call the ARDS net protocol to 6 mLs. So we took his tidal volumes, we cut them in what? Half. And why do we do these horrible things? Because it improves what? Survival. So what physiological changes would you expect by doing the right thing? And it's increased compliance and oxygenation, decreased compliance and oxygenation, no change in either one, decreased compliance, increased oxygenation, increased compliance, decreased oxygenation. Think about my hand being the alveoli. Low tidal volumes. Let's see what everyone picked. All right. So how do I approach this question on the boards? Number one, is this a great question for the boards? The answer is what? Yes. Because it's talking about concept, not memorizing. So when I get this question on the boards, what's the first thing I do? And you could laugh at me. I do this. Take a deep breath. Now you enjoy the question. So what is it really asking? Let's play the game. Here's an alveoli. And if it's getting 12 mLs per kilogram of body weight, tidal volume, what's going to happen when I cut it in what? Half. Is that alveoli going to distend or is it going to shrink? It's going to shrink. Well, we can't use the word shrink, in medicine. If your alveoli is shrinking, what's the medical word for the alveoli kind of shrinking, collapsing a little bit? Atelectasis. So when you have atelectasis, everyone, what happens to surface area in the lung? It decreases. Therefore, what happens to diffusion of oxygen? Decreases. And when you have alveoli that are shriveled up like a balloon that's all shriveled up, does that make your lung more compliant or less compliant? Less compliant. So what's the answer here? B. Wait a minute. Now, being a pulmonologist, do I like my patient's lungs to be non-compliant and hypoxic? That's kind of a mean thing, right? So who could tell me, bonus question, what on the ventilator will counteract the effects of the low tidal volumes? PEEP. What does PEEP stand for? Positive end expiratory pressure. It's kind of like this. You're blowing out. Think of a valve that closes on expiration. And what happens when you have PEEP? What's going to happen to the alveoli? They're going to what? Distend. And now that they distend, what happens to compliance? It improves. What happens to surface area? Increases. What happens to oxygenation? Gets better. And what's the take-home message? Really, managing ARDS on the vent is just a balance between what? Low tidal volumes and PEEP. Ta-da! How easy was that? All right. So I just put this for your own edification, some advanced things for ARDS. ECMO got really popular during COVID times. It's kind of like dialysis of the lung. It's not commonly done. It's not a treatment. It's a bridge. A bridge to what? That's the question. Maybe transplant. We don't use high-frequency jet ventilation in adults anymore. There's some data that may increase mortality. APRV is a very specific mode of ventilation. And the take-home message is that there's not one mode of ventilation that improves mortality and survival in ARDS. This is like a glorified inverse ratio. We have a very long inspiratory time and a very small expiratory time. Prone positions and paralytics. For paralytics, there was initially data that said, hey, paralyzing someone may improve mortality. Follow-up study shows no. You should paralyze only if you need to clinically, but don't do it empirically to improve mortality. Prone position, well, this is just between me and you. Does prone position decrease mortality in ARDS? The answer is yep. And this is the study. We carried this data over during our COVID-2 pandemic. And you really have to prone these patients early, and you really have to prone them almost 16 hours a day. And I said this already, that no ventilator mode has been proven better than another. I gave a very, very common setting over here. And most people, when we talk about picking a vent setting, we use what? Probably volume assist control. We'll always initiate 100% FiO2, then wean it down as possible. If I even think about ARDS in anyone, I always give lower tidal volumes. And I usually start the PEEP at 5, and I'll titrate up based upon the what? The plateau pressure. So my last slide, I'm not lying, this really is the last slide, is that I really wanted, well, maybe I lied, 2 slides. So why did I put this here is because, does anyone find it a little confusing about peak and plateau pressures? It is, So let me just say this one little thing is, when do I use a peak and plateau pressure? The key message for everyone listening today is we really only use this when you're on one mode of ventilation, volume AC. You're going to ask me why? Is because there's only 2 main ventilator modes, volume and pressure. And both are good. They both accomplish the same thing, is to help the patient. But remember, when you pick a volume mode, what's going to be variable? Pressures. When you pick a pressure control mode, what's going to be variable? The volumes. So what happens is, when do you use a peak and plateau pressure is when you're on a volume control mode, volume AC, and all of a sudden, to get the same amount of volume, the pressures are what? Shooting up. So that's why they have a very high what? Peak pressure. And the minute the peak pressure is high, the question is, why? Is the problem getting the air flowing into the lung because of resistance in the airways or in the tubing? Or is the problem because there's a compliance? So how do I know if it's going to be a resistance or compliance problem? I check a what? Plateau pressure. And a plateau pressure is an end inspiratory hold. So at the end of inspiration, a valve shuts at the end of inspiration, and it tells me if the pressure is high or it's low. So how do I pair this together? Right here. In both settings, there have to be a high peak pressure. Why? That's the main reason I'm doing this. And what mode are they going to be in? They're going to be in a what? Volume assist control. So if they have a high peak pressure, but there's low plateau, that means it's all about resistance to getting the airflow in. So mucus plug, bronchospasming, biting on the ET tube. But if there's a high peak and high plateau, it's a compliance problem. And what is the take-home message here? ARDS. And that's what we're talking about.